Our next speaker is Dr. Daniel Epner. Dr. Epner is a palliative care physician at MD Anderson Cancer Center, who has practiced medical oncology for several years before moving to the Department of Palliative Care in 2012. He began his faculty career at the Baylor College of Medicine as a principal investigator of a basic science lab, but he now focuses on psychosocial aspects of oncology. His primary academic interest is communication skills training for palliative care fellows and a variety of other providers. He uses narrative medicine techniques to teach communication skills. Such skills include reflective writing, close reading of medically themed stories, and discussing films relevant to clinical practice. In recent years, Dr. Epner has contributed several reflective pieces about his own experiences as a doctor to the Journal of Clinical Oncology, Annals of Internal Medicine, JAMA Oncology, and other journals to serve as enduring educational resources. He is authoring a book entitled Empathy, Real Stories and a Practical Step-by-Step Approach for Busy Clinicians, scheduled to be published by McGraw-Hill in late 2021. The title of his talk today is Helping Gravely Ill Patients Focus on Living Well Rather than Dying Well. Welcome, Dr. Epner.
Hi, Arnav. Can you open my video, please, or enable my video?
Yes.
Okay, thank you. Thanks for inviting me. It's really a pleasure to be here. It's quite the honor. And Marcia, I never get to see you anymore because of this virtual thing, so it's great to see you at least virtually on the computer. Yes, I'm really honored to be here, and I want to use a little visual aid here. So I'm going to share my screen. Let's see. And please let me know if you can't see that and we'll adjust it. Can everybody see the screen and hear me? Okay, I take that as a yes.
Yeah, we can hear you. And see, we can see the screen.
Okay. Thank you for the kind introduction. As Dr. Brennan was saying, yes, I work in the palliative care unit at MD Anderson, but also actually most of my work at MD Anderson is working as a consultant in palliative medicine in a very big hospital, MD Anderson, and also working in our clinic. And the kinds of scenes that Dr. Brennan just described are very relevant to my work part of the time. Those people have already committed to a path of pure palliation, pure comfort. But a lot of our patients who we see from day to day have not yet committed to that path. In fact, one of the things we do is help them decide about big decisions about their health care. And when they reach particularly a crossroads when the treatment is no longer working well, we help them navigate those really difficult decisions. So I'll make this pretty brief. This is going to be a very focused presentation. And this presentation is going to be very practical. So I hope that some of the participants here today are planning a career in medicine, or maybe they already have a career in medicine. I know Dr. Mahoney is a palliative physician at TCH. If you're not actually going to enter or haven't already entered a career in healthcare, then hopefully this talk will be useful to you just in your everyday life. So here's the agenda for today. I'm going to share with you a story worthy of our attention. And you might be wondering, what kind of story is that? And I'm here to say, and I think Dr. Brennan would agree, that every single story we hear from our patients and their families are worthy of our attention. The stories I heard today and the patients I've seen and the ones I'll hear tomorrow are all worthy. And the only limitation, of course, is time. So we do the best we can in the time that we have. But I'll share kind of a typical story. And then I'm going to talk about how obstacles can be opportunities. So any substantive conversation, any important story, whether it be a film, a novel, a patient narrative, or a family narrative, anything that's, important is going to be imbued with strong emotion And often that emotion in my line of work is negative emotion. But we can turn that into an opportunity for us and our patients. And I want to talk about a thing called empathy, because empathy is the language we speak when strong emotion enters the conversation. Now, I know everybody on this call today, in this symposium, is really tuned into empathy. And they've heard a lot about the philosophical and theoretical and hypothetical and conceptual difference between empathy, sympathy, and so forth and so on. But what we're going to talk about in the next few minutes is what empathy sounds like in the clinic, in our conversations with real patients and real families, according to at least one person. But what I'm going to present today is representative of the consensus, I think, amongst people who practice medicine and are tuned into the psychosocial aspects of medicine. And then I'm going to talk briefly about this key principle of autonomy, which is one of the 4 key medical ethical principles. And I want to make the point that when we have conversations with our patients, when we share narrative and receive their stories as generously as possible, that we respect their autonomy, of course, but that autonomy is a reciprocal process, because the healthcare team also has a worthy view that, and the healthcare team has agency that's valuable. Okay, here's a very generic story, and you know, I saw somebody just like this yesterday, and literally every day. So this is a gentleman, and this is, so today I'm on the consult service. I'm not in the palliative care unit as Dr. Brennan just described. I'm going around seeing people, and I was yesterday as well, you know, seeing people who are hospitalized, and we're helping them navigate, you know, taking care of their symptoms and navigate difficult decisions. So this man came from a faraway land, doesn't matter where. English is not his first language, and he has refractory malignancy. It's not getting better, and it won't get better. He's received all kinds of therapy. Doesn't matter what kind of cancer it is. Now he's debilitated. He's bedridden, and he can't even sit up in bed, really can't eat. His body can't use nourishment anymore. And the treating team wants to stop offering treatment, rightfully. And the patient is resistant. I'm sorry, the family is resistant, and the patient resists this move toward a purely palliative approach. Now, the young adult son says, and this is a 28-year-old man from a far-off land, says, "Don't tell my father any bad news, he'll give up all hope." And this is a typical scenario that we face, and we could spend literally hours and hours and hours talking about each little aspect of this, but we're going to focus on just a few little points today. You know, he's never going to give up the fight. And when we receive a story like this, as a practical matter, as a clinician, you know, we have to grapple with what do we do with this? We receive it, but we have to do more than just receive stories. We have to help people make good decisions, so that, you know, our job is to stamp out suffering, to reduce suffering, to help people live better. And a lot of times when I introduce myself and I say I'm a palliative physician and an oncologist, they say, "Palliative? Oh yeah, you're one of those doctors who help people die well. You help them die." And I said, "No, I don't know what happens after death. That's a great mystery. My job is to help people live well. That could be an hour, it could be a day, we never know." Okay, so when we talk about, you know, obstacles being opportunities, this is what I mean. We're talking about conversations. You can imagine, just think about this. I'm sure you imagine being, first of all, sick. I mean, when I have any kind of medical issue, it's terrifying. And I don't even have any major, thank God, medical issues. But imagine somebody who has a grave illness, and they're even life-threatening, And now they have to be hospitalized, no less. And to make matters even worse, their family, maybe one person can visit, but they can't receive their family there, so it's miserable. Their kids can't come. It's really terrible. So people are feeling this fear, this helplessness, something that we feel sometimes ourselves, sadness, grief, anxiety, of course. Now, why is this an opportunity? And it's because when negative emotion enters the conversation, it gives us an opportunity for empathy. And empathy is this glue, this raw material that helps us connect with other people. You know, we try to imagine what it's like to be in their shoes, to be in their, in their situation. Now, I want to talk about a particular form of empathic expression, because if you look at the literature, there's a Journal of Clinical Oncology paper from about 10 years ago in which the authors talk about the different forms of empathic expression. And we don't have time to go into all that today, but I want to tell you about one particular way of expressing ourselves in the clinical milieu that's really powerful, and it's to respect the other person, the patient, the family. And the thing that we want to talk about today is, again, not conceptual, not theoretical. I'm going to show you the actual words that we use in the clinic, or I use. And the book I'm writing is expressly for that purpose, to tell people, exactly what it is they can say. Because a lot of people, most people know what empathy is on a conceptual level, but when it comes to practice it, it's like playing tennis, learning it from a video, instructional video, or reading a book about tennis, and then they get it on the tennis court, and it's a different game than watching a video or reading a book about tennis. It's the same thing. People know what empathy is, but they clearly don't know what to say, and so I want to share a few examples. Okay. So, young man says, we're going to fight this thing forever, we're never going to give up. And the medical team would be tempted to say, well, we've talked about this. I wish, we really can't give you any more treatment. It's time to go to hospice. That kind of approach is a factual, a true approach, a direct approach, but it's a biomedical factual answer to an emotional expression. And it's important for us to take, to use empathy, which is on that same emotional plane. So saying something, I respect how you're fighting for your father's well-being, is really powerful, more powerful than you can appreciate. And the other thing I'll say about these kinds of phrases, like you've traveled so far to support your family, to acknowledge that is very respectful. But lest you think we say these things to somehow manipulate people or get them to do what we want. No, it's not anything about that. We say these things to connect in a meaningful way, because when we say these kinds of things to patients and their families, we mean them from the heart. I mean them. And if you mean this, then people know it, and they know you're trying to take care of them the best you can, and then we can connect and we can really move forward almost all the time. Acknowledging this young son, he's carrying a heavy burden on his shoulders. He's the oldest of 9 children. And his responsibility is to take his father to America, cure him, and bring him back home and fully restored. That's a huge responsibility, and acknowledging that is important. I'm inspired by the love between you and your family. You're doing an amazing job of advocating for your father. I've even told some people, you're a rock star. You inspire us. In fact, I said that this morning. I saw a young woman, really tough situation, very advanced malignancy. She's 23, and she's just handling it amazingly well. And I just said, I acknowledge that, and I think that's a way of connecting and respecting her. Thanking people for helping support their relatives, the patient, and really supporting the healthcare team in this journey. Asking something exploratory, how are you holding up? Is it through your, they'll say, well, it's through my faith, I believe in God. and respecting that, saying, or how do you find strength, but then you're saying, I really respect your strong faith, rather than fighting this, thinking it's maladaptive to cope that way. It's really quite adaptive to cope in this way through religion. And then here's a few other examples. I had many patients who were, as an example, who have been, as an example, elementary school teachers for 40 years. And I say, you know what? Your work is or was extraordinarily important work. And you should be proud of how many lives you've touched and shaped. And I bet the kids, and they say, yeah, the kids still come back and talk to me and visit with me. Acknowledging somebody's faith and hope. Hope is something that cannot be stolen. We can't take hope from anybody. That's inside everybody. And acknowledging that's powerful medicine, arguably more powerful than any kind of chemotherapy, is really healing. Asking somebody what they hope for, if we can't achieve cure, creates more empathic opportunities. And just respecting, you see this next phrase, you're doing incredibly well under the circumstances. You're coping really well. You inspire us. Acknowledging how hard it is to be in a hospital during COVID. Nobody's visiting. That's actually horrible to see it, but it's 1,000 million times worse to actually experience it. Okay, so you get the idea. This is, as Aretha Franklin, RESPECT, respecting people is a very deep and genuine form of empathy. Just a few final words. Reciprocity of autonomy, which is to say that a well-intentioned, compassionate, skilled, knowledgeable, physician or healthcare provider has agency, and that guides our conversations. And when we have these conversations to help compassionately direct people who need help with direction, not by being paternalistic or patronizing, but by directing people who need our help, we're showing our compassion toward them, and we're creating this reciprocity where our voice is important as well through experience. Now, many people will say, medical providers sometimes euphemize, and they try to hide the truth, or they don't tell the truth. And it reminds me of this famous movie scene, A Few Good Men, from many years ago. Colonel Jessup saying, you can't handle the truth. And I'm here to say the literature shows, the medical literature and my own experience shows, not only can patients handle the truth, they need the truth, they want the truth, almost always. And so it's important that we give them the truth. But they don't want to be hit over the head with a sledgehammer. They want the truth in a compassionate way, in a healing, nice way. So these are some examples, and the book we're writing is going to be full of dialogue and examples and teaching points and practice points. But these are just a few examples of words that we say where people don't have to wonder, a clinician, a physician doesn't have to wonder, what am I supposed to say? Well, saying, I wish we could do more for you, I wish we had better options, is a really empathic thing to say, instead of promising something that can't be delivered. Again, exploring somebody's goals at this point and saying flat out, I took the Hippocratic Oath to do no harm, and I'm going to honor that promise. I wouldn't say this to a patient, really, but our job as healthcare providers is not to harm people, and so we have no obligation to harm people if they want something from us that's not helpful or is harmful. Okay. And sometimes saying, it's time to focus on comfort and dignity. I know you're a fighter, and I respect that, and we're fighting with you. What are you fighting for? Okay, so you get the idea. More language here. I can only imagine how discouraging it must be for you to hear this. These are just a few little examples of things we say in the clinic that are empathic. So with that, I'll stop. I hope that was a very practical look at the topic, And during the discussion, maybe we can have some questions and comments. Thank you so much. Here's my contact. And I want to sharing.
Thank you so much, Dr. Epner. Thanks for your insights on how to improve empathy, especially within palliative medicine.